Greetings. I'm Dr. Richard Elcorta, the Acting Co-Executive Director and State EMS Medical Director for MIMS. I'd like to welcome you to the 2018 Maryland Medical Protocols Base Station Update. MIMS, the EMS Board, and the citizens of Maryland thank you for taking the time to complete this EMS update as it advances the practice and delivery of EMS services across Maryland. Through this educational process and annual EMS update, Maryland is able to stay current with the advances in EMS care. One of these advances involves the expansion of the acute endovascular intervention window for treatment of acute stroke. The DIFFUSE and DAWN trials demonstrated that patients with large vessel occlusive stroke, who also have a small core of infarct and large penumbra of salvageable brain, and are outside the 4.5-hour fibrinolytic window, up to 24 hours, will benefit from endovascular clot extraction. This change has an impact on both EMS and emergency medical care of stroke patients. MIMS has directed EMS providers to manage new onset stroke up to 24 hours as a priority 1 stroke patient and divert these patients to a primary stroke center. The primary stroke center will then perform an evaluation to determine if the patient has a large penumbra of salvageable brain. It is then the responsibility of the primary stroke center to get the patient to an endovascular capable center for clot extraction. EMS providers will no longer require medical consultation to administer calcium chloride for suspected calcium channel blocker overdoses or hyperkalemia. As the Easy Tube is no longer being manufactured, MIMS has replaced it with the King LTSD for the Advanced Life Support Provider Alternative Airway device in the arrested patient. In an effort to reduce pain and reduce hemorrhage due to pelvic fractures, the pelvic binder is now an optional supplemental protocol. Ketamine has been added as a new medication. Ketamine will be replacing the use of Haldol for excited delirium at a dose of 1 milligram per kilogram IV or IO up to 100 milligram maximum single dose. Midazolam may be added for the persistently agitated patient. Ketamine can also be used for moderate to severe pain management at a 0.2 milligram per kilogram IV or IO dosing to a 20 milligram maximum single dose. Medical consultation is not required to administer ketamine. There have been multiple changes to the cardiac arrest and termination of resuscitation protocol. We are moving from a 15 minutes of minimum care to 15 2-minute cycles of high-performance CPR and appropriate interventions before considering termination of resuscitation in the field. EMS providers are working closely with their local law enforcement and the medical examiner's office to reduce the transport of patients who died on the scene. This will reduce the risk of providing false hope to the family, reduce risk to the family, EMS providers, and the public from motor vehicle collisions, from unnecessary transports, and hopefully prevent generating additional costs for the family. It is very important that the emergency department be prepared to receive deceased patients who may be transported and pronounced by EMS prior to ED arrival. There are clear indications when situations at the scene can pose unsafe situations for EMS providers. These include, but are not limited to, unsafe environment to attempt resuscitation, need for family support, particularly with SIDS. For patients under the age of 18, a pediatric base station medical consult with Johns Hopkins Children's Center or National Children's Medical Center may occur in rare instances for termination of resuscitation, as some of these cases may be futile and are complicated by family and EMS dynamics. eMeds is being upgraded to Nemesis 3.4 and the Elite platform. Maryland's EMS electronic patient care record is being upgraded to the Nemesis National EMS Information System version 3.4 and the ImageTrend Elite platform. The new platform will improve patient documentation and align with the HL7 code, meaning data can be uploaded into the Health Information Exchange, such as CRISP, a function that MIMS is pursuing over the next year. The hospital dashboard will continue to display the EMS electronic patient care report of each patient delivered to your hospital. Public safety and commercial EMS providers delivering patients to the hospital will continue to be required to provide a MIMS-approved short form or a completed electronic patient care report, or eMeds report, for the handoff in the emergency department. Medication shortages. Critical emergency medicine and EMS medications have been in short supply or backordered on near chronic basis. Most recently, these medications have included fentanyl, diltiazem, ketamine, and most forms of IV fluids, particularly lactated ringers and normal saline. EMS has morphine as a fallback medication for pain management for ketamine and fentanyl. For diltiazem, the EMS board has approved the use of an old medication, verapamil, as the replacement for uncontrolled atrial fibrillation and atrial flutter. The EMS providers have been encouraged to use saline locks for medication administration and reserve the use of lactated ringers for the hypotensive patient needing volume resuscitation. Dopamine has also become unavailable. The EMS board has approved the use of an epinephrine drip as a temporary replacement medication for the indications where dopamine would have been of benefit. A stabilization center protocol is being implemented in Baltimore City. The stabilization center is staffed by nurse practitioners with the intent to screen, stabilize, treat, and refer patients who are identified by EMS providers as intoxicated with alcohol or responded to naloxone following suspected opioid overdose. The nurse practitioner will also be able to treat an opioid-dependent individual using buprenorphine with naloxone or Suboxone and refer them to a practitioner for ongoing treatment and maintenance. Under the new EMS naloxone Leave Behind pilot program, Per a direct prescription order from Deputy Secretary Howard Haft from the Maryland Department of Health, working with MIMS and the EMS board, EMTs, CRTs, and paramedics may dispense naloxone in an opioid overdose leave-behind kit whenever naloxone has been administered to a patient with a suspected opioid overdose if that individual received naloxone and improved from that administration. The highest risk group for lethal overdose are individuals who have overdosed once before. This naloxone leave-behind program is specifically designed to target these high risk of lethality patients. The public and law enforcement are using 4 milligram intranasal dosing, sometimes multiple doses, as a rescue intervention on suspected overdose patients. Emergency medical responders, who are often first in the ambulance or first on the fire apparatus, can now administer naloxone. Many EMS providers are experiencing compassion fatigue related to the opioid crisis. MIMS and I are asking you to please help us change the culture of apathy regarding the substance-dependent individual. Please share with the EMS providers all the actions that your hospital is doing to provide follow-up, peer recovery specialists, and rehabilitation referrals. This is a call to action to reduce the morbidity and mortality related to opioid dependence. In summary, thank you so much for providing base station medical consultation and supporting the EMS providers who are responding to spectrum of 911 calls. With your assistance, EMS is able to transport patients to the most appropriate facility for optimum patient care, which in turn reduces their morbidity and mortality. The EMS staff at MIMS, the EMS board, Pat Gaynor and I, as acting co-executive directors of MIMS, wish to thank you for all you do to make Maryland's healthcare and EMS system as robust as it is.